I'm terrified of needles. I will not get an IV.
IVF is where we stimulate the ovaries, and really we're hoping for more maximal stimulation. FSH is the hormone that we give through injections. Over 2/3 of women had significant anxiety surrounding the injections. 20% of the people that had anxiety said that they delayed coming in our door.
And you created something called needle-free IVF.
It just looked so unfriendly. It looked so invasive. I was scared of undergoing it. I hate needles just like you. And I was like, wow, there has to be a better way. What we go through has been misunderstood, mischaracterized, and a lot of it ignored. Now's the time that we start critically evaluating it. And over 3% of babies in this country are born through fertility technology.
Hi, I'm Ronit Wenatal, co-founder. Today we talk to Dr. Rachel Mandelbaum, reproductive endocrinologist and fertility specialist. We dive into the world of assisted reproductive technology and talk about IVF, IUI, who is it for and who's it not for. We also dive into egg freezing. We talk about innovation in the space, including needle-free IVF. This is a juicy episode. You're not going to want to miss it. I'm so excited to have you here and talk about everything and anything ART. Welcome to the Fertility Masterclass, Dr. Mandelbaum.
Thank you. I'm so happy to be here.
Let's jump in and talk about just generally, what is ART and what are the different types?
Sure. So ART stands for Assisted Reproductive Technology, and really, there's two main types. One is where we call it intrauterine insemination, or IUI. And basically, the way to think about it is we're just maximizing the efficiency of the machinery that the body naturally uses to create a pregnancy. So using natural ovulation, using the fallopian tubes, and putting a very concentrated sperm sample up at the top of the uterus, closer to where they need to go, where fertilization occurs in the fallopian tubes. The other type of treatment is in vitro fertilization, or IVF. And this is more of the heavy hitter treatment, right? This is where higher success, more expensive, more invasive, but there are a lot more opportunities with IVF to save embryos for the future. A lot of people might start with IUI and eventually end up with IVF. But basically, IVF is where we stimulate the ovaries, and really we're hoping for more maximal stimulation, so as many eggs as possible. And we retrieve those eggs with an egg retrieval, take the eggs out of the body, fertilize them with sperm in the IVF lab, create embryos, and then transfer the embryos back into the uterus to create a pregnancy.
Got it.
It's a lot.
It's a lot. So IVF is technically like the process of freezing your eggs plus the additional process of getting that sperm, fertilizing the egg, and then taking that embryo, either freezing it or using it.
Exactly. So freezing your eggs is really half of the IVF process. They're identical from the ovarian stimulation phase. So we can kind of split IVF into stimulating the ovaries, or what we call ovarian stimulation. And then once the eggs come out of the body, this is where egg freezing versus creating embryos for IVF, either to freeze the embryos or transfer them, differs. So with egg freezing, we freeze the eggs up front before they're fertilized with sperm. And with IVF, or embryo freezing, we're fertilizing the embryos, growing them to embryos, seeing how, because there's quite a lot of attrition in the IVF lab in terms of not every egg will fertilize, and not every fertilized egg will actually grow into an embryo that can be transferred into the uterus. And this is natural physiology. We just see, for example, let's say we get 12 eggs, right? We're seeing a year's worth of eggs at once. So human reproduction is very inefficient, and we expect that there's going to be this funnel to create embryos. So when we're creating embryos for IVF or embryo freezing, we're seeing that in real time. So when you're freezing eggs, you have to go through this whole process of IVF, meaning fertilizing them, creating embryos, but you do so on the back end when you come back to use the eggs.
And then it sounds to me, based off of this like inefficient physiology that we have, that if you do freeze your eggs, and let's say you do get 12 eggs, you are not necessarily able to use all 12 of those. So is there a way to kind of test your egg quality at that phase?
Great question. So no, and that's where counseling women about expectations with egg freezing becomes a little bit difficult, because when eggs come out of the body, we know very little information about those eggs. And what egg quality really refers to is the ability of the egg to divide its genetic material in half. And so all of our cells in our body have 46 chromosomes, and the egg needs to only contribute 23 to an embryo that will hopefully also have 46, because sperm will contribute the other 23. And so as we age, there starts to be more errors in the egg not contributing that perfect 23 number. And we see either extra or missing whole chromosomes or partial chromosomes in the eventual embryo. The problem is we can't test that in the egg. So we don't know which egg has the perfect 23 and which one has 24 or 22. We can only test that in the embryo once the embryo grows to what we call the blastocyst stage, which is an embryo that has between 100 and 300 cells and is at the physiologic stage that it would implant in the uterus. So the biggest predictor of your egg quality is your age. And so that is why egg freezing is such an incredible technology, because you are freezing your egg quality at the age at which you are freezing them for potential future use with IVF, knowing that egg quality will decline with time and that the percentage of eggs that you'll get more will be normal because you froze them at an earlier age.
Interesting. And so if somebody goes through egg freezing, what amount of eggs are you comfortable with to say to them, okay, this was a successful egg freezing cycle, you're good?
Yeah. That really is dependent on someone's age. And I think it's an individualized decision because, egg freezing is never a guarantee. And the reason why is because, like we talked about, not every egg will fertilize, not every fertilized egg grows to an embryo, and not every embryo implants in the uterus. And so we have data, populational data, that we can use for women at every age to be able to say, okay, how many eggs should get you to that 80, 90 and above chance of a live birth from these eggs? But remember, that data comes from women who've gone through IVF and have, taken eggs out of the body, fertilized them, created embryos, and then either we biopsied them to understand, is that embryo euploid or normal, or has that perfect 46 number of chromosomes, or has that embryo created a pregnancy? So we are really extrapolating that IVF data to women using frozen eggs. And we know that frozen eggs work well because we use donor frozen eggs all the time, right? But we are extrapolating that data. And so the number that I recommend for someone to freeze increases as we get older. That's because there are still normal eggs there, but they're harder to find in the whole pool, right? If I get 12 eggs from, a younger person, I expect that more will be normal compared to if that female was 40, right? Then I know the vast majority are going to be abnormal. So I need more to be able to overcome the fact that most are abnormal, right?
And what are your thoughts on the concept of chronological age versus biological age? Because I know that, for instance, back when I was 41, I tested my biological age, which I looked at my telomeres, and my biological age basically indicated that my cells were aging at the rate of like a 32-year-old. So like from my perspective, it was like, okay, like the diet and lifestyle and all the things that I'm doing are kind of helping me age slower, if that makes sense.
So I think understanding your biological age is helpful for overall health and a marker of how well you're caring for your body. And certainly, all of the lifestyle things affect the integrity of our DNA and our cells and telomere aging and all of this. Ovarian aging is difficult because that is a different process to aging in the rest of our bodies. And this is why the ovaries age on a more accelerated timeline than the rest of our bodies, right? We're born with all the eggs that we'll ever have. We can't create new ones. That's in juxtaposition to a lot of the other cells in our body, which are constantly dividing and repairing and all of that. So the fact that we have this limited supply in our ovaries and they're in this vault, and every month the ovary lets out a group, right? But it's not until the point of really when the egg is just about to be ovulated or released that the egg has to divide its genetic material, as we talked about. And ovarian aging is different. It's not like, aging with telomeres like the cells in the rest of your body. It's really that we call it the meiotic spindle, or the machinery inside the egg that's necessary to pull apart those chromosomes into 23 and 23, and is more prone to making errors as we age.
Yeah.
So all of these lifestyle things are really important, and they're modifiable things that we can do to affect egg quality. But it's not, age is really what trumps all in the fertility world, right? These lifestyle things help. I kind of think of it as when we're talking about chronological age, right? That I think is really important for number of chromosomes, and kind of this biological age, or what you're getting at in terms of integrity of DNA quality, right? Kind of instead of number of pages on the book, words on the page, right? That is where I think lifestyle things can really come into, importance, right? In making sure that there's not as many DNA breaks, that there's not random mutations that happen in DNA in all of our cells as we're exposed to toxins or environmental things we eat, things we do, these reactive oxygen species and oxidative stress.
So, and what about mitochondrial function, and how does that impact? Because I feel like as you age, your mitochondrial function declines, and that could be one of the reasons why aging, of course, your eggs, like the vault, gets emptier and emptier, so you have less and less eggs. But as far as the process of meiosis, the biggest impact is your mitochondria, right?
Yeah, so mitochondria are the powerhouses of the cell, right? They're incredibly important for cellular functions, and we know that the more mitochondria, the better, right? And so certainly I think that's where we know that a lot of the supplements come into play, is helping fuel the way that mitochondria work and more efficiently creating energy for the cell to accomplish all of the cellular jobs that need to happen for meiosis to occur. So I think you're very right. I mean, I think that that's where these lifestyle things come into play. And I think that it plays a role, just, maybe not as large of a role as age. I think I'm really trying to drive home, that age is really something that we can't get around, right? But it is what it is. And so I think where the focus is that there are modifiable things that we all can do to say, okay, well, I'm 40, but I'm going to be the best version of 40 that I can be in terms of my egg quality, right?
Yeah. And then do you think that age, as far as just like I'm sharing my own personal story. So I got pregnant naturally with baby number 1 at the age of 38. And then I gave birth to baby number 2 at age 42. All of those were natural. And I'm imagining if I probably went through IVF, I probably wouldn't have had like such high success, because I probably wouldn't have gotten as many eggs. So I'm imagining that like at a later age, maybe success of IVF goes down, but you can probably get pregnant naturally if you do all the right things. I don't know. What's your perspective on that?
Yeah, so you're hitting on something that is an interesting question in our field. I mean, the IVF process is not analogous to natural conception, right? This is a completely different process. And I have patients who don't do as well with IVF and then get pregnant naturally. And that's because it really is a different process, right?
Yeah.
IVF is all about numbers, and we meet more success the more eggs we're able to retrieve, and kind of the better we're able to withstand that funnel that we talked about, that attrition in the IVF lab. And natural conception is very different. It's all about the ovary selecting one egg to ovulate, right? And then the fallopian tube picking up that egg and it meeting sperm in the body and creating a pregnancy that way. So they are very different processes. And I think particularly for women who have a lower number of eggs, that's where we get to, fertility history. A lot of people will choose to do IVF electively, right? They haven't necessarily tried to conceive naturally, and they choose to undergo IVF, whether they're delaying childbearing, whether they're trying to select against a genetic condition. There's many, many, many reasons people will undergo IVF. And sometimes we get women who have a lower ovarian reserve, and IVF just becomes more inefficient. That's the word I like to use, is inefficient, because we can meet success. It just might require multiple rounds to really get the numbers that we need to meet success in the IVF lab, which is a very different thing than natural conception, where we're always working with one, maybe two in the case of twins, but really just one egg,
so you need sperm. One good egg and one good sperm.
And one good sperm.
Yeah.
Yeah.
Yeah, so interesting. And so then as far as the options with ART goes, IVF versus IUI, do you always start with IUI and then graduate to IVF? Or how does that work?
No, and I think that it really depends on the patient and their family goals, right? The thing about IUI is it's a nice starting place for some people who aren't ready to move to IVF, but it can be quite frustrating, right? It's very involved. You're still coming into the office several times. We have these extended waiting periods where we're waiting to see if somebody's pregnant or not. But really, success peaks at about 10 to 15% per IUI.
Oh, wow.
So it's very low. Now, that might be slightly different for somebody who isn't trying to get pregnant, for example, like a same-sex couple or something like that, where they don't necessarily have infertility. They're doing IUI for a different reason.
Yeah.
But really, the success rates are a lot more modest. And we know that there's a plateau there, right? We know that about after 3 to 6 IUIs, and I err on 3 in people who have infertility, that there's kind of flattening of that success curve. And so that's when we move to IVF. The advantages, though, of IVF are that we can not only use an embryo for baby number 1, but then we can create somebody's family through IVF, so that, if there were factors at play that are affecting chances of baby number 1 and infertility, those same factors might still be there for baby number 2 and 3. So
if not, would probably get worse.
Right. And then at that point, you know that, okay, numbers of eggs are going down and quality is going down as well. So is it in that person's best interest to really do IVF, freeze enough embryos for the family that they want? And then, sometimes I even backtrack that and I'm like, okay, because I actually think about when somebody comes to me, the most important question is, what is the family that you envision? Do you envision a big family, a small family? Do you want 3 kids, 1 kid? If they tell me 3, then I actually reverse the thinking. They're very focused on that first baby. And I'm actually thinking, let's think about baby number 3 before we're thinking about baby number 1 and 2. Because we could even do IVF to freeze embryos for baby number 2 and 3, and then try a couple IUIs now while you're younger and trying for baby number 1. But we have baby number 2 and 3, as best as we can, secured in the freezer.
Yeah.
So it's really just a different way of thinking about family planning and how you, build your dream family, kind of reverse engineering, if that makes sense.
Yeah, that totally makes sense. And let's talk about the male that comes in. So a couple comes in, they have infertility at Wenatal, and our biggest aha when we had miscarriages, both Vita and I, were that wow, this could have been because of my husband. It never occurred to us that sperm has such a big impact. So when a couple comes to see you, what's your protocol with the men?
So We always review, I mean, I want to know all these lifestyle things, what they do for work, what are their exposures, what their diet and lifestyle things are. Do they enjoy saunas, hot tubs, all of these things where we're looking for risk factors for sperm quality. So the thing about sperm is that the life cycle for growing a sperm is about 3 months, right? And spends about 2.5 months maturing in the testicle, and then spends about 15 days outside of the testicle until ejaculation. And so during that time, sperm is subject to all the influences of lifestyle things, right? Hot temperature is bad for sperm. That's why the testicle is located in the scrotum, kind of removed from high body temperature. So if somebody's telling me that they're spending every day in the sauna at the gym, I'm like, okay, well, we got to change that. Environmental things, work exposures, all of these things can really affect sperm quality. So
like what type of work exposures?
Like, it's funny, I just gave this lecture to a lot of female physicians. And so what's on the top of my head is like formaldehyde, radiation, all of these, toxins. If somebody's a contractor, right, they're around all of these, toxins that go into insulation and all of these things, right? We don't think about it, but really there are, or if they're in agriculture, right, there's a lot of things there. Or if they're a pilot, right, there's radiation up in space radiation. So there's a lot of different things that you can actually piece apart based on what somebody does and what their lifestyle is that may affect their fertility, right?
Yeah, even like sitting all day long.
100%, 100%.
That creates heat, right?
Yeah. Or what type of underwear do they wear? Do they wear boxers? Do they wear, tighter underwear that put more pressure and increase the temperature there? Are they bike riding every day? All of these things are kind of modifiable things. Now, it's not to say that everybody has to make these changes, right? So we start off with a semen analysis. And a semen analysis is really a pretty crude measure of sperm, right? So a semen analysis really just tells us what's the concentration or number of sperm there, right? Are they swimming normally? Do we think they're swimming forward? So kind of extrapolation of can they reach the egg?
Yeah.
And what do they look like under the microscope? Do they have one head, one tail? We have very, very low standards. Only 4% need to look normal.
Oh, wow.
And this is because with the male, they are kind of the opposite of the female in that they overcome quality with quantity. And so in an ejaculate are millions and millions and millions of sperm, and really only 200 are really making that trek to meet the egg. 99% are lost out of the vagina after intercourse. So we start with a semen analysis, and I think from there I'm able to say, okay, is this completely normal? Is there sperm present in so much quantity that we can overcome some of the quality issues? Or do we really need to dissect somebody's lifestyle, figure out where we can modify to really improve sperm quality?
That makes sense. So what are some of the lifestyle factors that you speak to both the male and the female that influence fertility?
Yeah. So I think the first thing is diet and exercise, right? What we put into our bodies is the most important thing in terms of diet, right? Are we getting fruits and vegetables, antioxidants in our diet? I always tell people like eat the rainbow, colored foods that have these antioxidants that are so important. Are we getting environmental exposures in terms of food preparation, like microwaving plastic containers, putting hot food in plastic containers, all of those things. So those
styrofoam to go. Anytime I see styrofoam, I run.
Exactly. All of those kind of modifiable things. Then exercise is a really important thing kind of for our overall cardiovascular health. And I think also our ability to kind of manage some of this toxin load.
Yeah.
And so that's where kind of we start. I think then is where if we either need more than I think somebody can get from their diet, or we have kind of a deficit to start, I think that's where supplements are really, really important and helpful, right? And so I think an antioxidant is helpful for female and male. We talked about how sperm is subject to all these lifestyle things that increase oxidative stress. But then the really interesting thing is that when sperm then fertilizes the egg, their DNA is the DNA. That's what it is. The egg is what actually has to repair that DNA so that it can become part of the embryo's DNA and genome. And so it is important for both partners because the egg has to repair whatever damage there is in the sperm. So I love how you guys have for him and for her, because it is a couple sport, right? We need both, to have that optimal environment for not only preventing, because that's part of what antioxidants do, is kind of preventing DNA damage in the first place.
Yeah.
But then also providing the energy to then repair DNA damage if it is there.
So that's so interesting. We talked about a little bit about this when we spoke last time. So essentially the egg needs to overcompensate for any flaws in that like sperm DNA.
Yeah. So the egg is responsible for those first couple days after fertilization. The eggs, all the machinery in the egg is really what is responsible for maintaining the embryo for those first couple days until then the embryo's DNA takes over. But of course, the embryo's DNA is a combination of the two. So the egg is of critical importance. So it's not just the male partner that needs to be, making these lifestyle changes or taking antioxidants. It's both.
Yeah, and my understanding was that is one of the main reasons why some couples have secondary infertility, because as a woman ages, her egg has less of that ability to kind of repair that DNA damage coming from the sperm.
Yeah, true.
So interesting. Okay, so let's shift gears into one of the things that I think like you're so excited about, and I'm so excited about what you do.
Yeah.
I am terrified of needles. Like I will not get an IV. I will like avoid the doctor at all costs because I'm terrified of needles. And you created something called needle-free IVF. Can you talk about that?
Yeah, so this is my baby, my passion project. So I'll start with kind of the story of how I created this. So I was a fourth-year resident, still in training, and I knew I was going to be thinking about IVF to build my family, kind of this reverse engineering like I told you about. I knew I wanted 3 babies, and that I'd probably be having a baby in my late 30s, and I knew that I had a very low ovarian reserve. So I was thinking about IVF. And at that point, I wasn't in this field yet, right? I was an obstetrician and gynecologist, a resident in training. And so I was really looking at IVF and the world of IVF from an outside perspective, if you will. I was obviously very interested in it because I was going to start fellowship soon. But it wasn't my everyday world, right? I was delivering babies and doing hysterectomies and all of that. And it just looked so unfriendly. It looked so invasive. I was scared of undergoing it. I hate needles just like you. And I was like, wow, there has to be a better way. And so I happened at that time to be working in a clinic for pregnant women who have diabetes. And I noticed how happy the patients were when they had the insulin pump instead of having to poke themselves so many times a day. And so the light bulb kind of went off and I was like, why do we not have this for IVF, right? We give so many injections in such a concentrated period of time and women are poking themselves. And, I think the injections also serve as a reminder to the female that the big brunt of this process falls on their shoulders, right? The male shows up at egg retrieval time and gives a sample, but the female's the one having to go through really the majority of the IVF process, all the poking and prodding, egg retrieval, all of that. And so I think the injections compound a lot of the anxiety and stress that females feel
100%.
undergoing IVF.
Yeah.
So the light bulb kind of went off, and that's where I decided, okay, I'm going to try this on myself. I'm going to be my own guinea pig and try it on myself in my own IVF cycle. So I did, and it went great. I had my 2 embryos sitting in the freezer for me. Um, but it went great. And I think that's what really opened the door to then a clinical trial, which we compared using the catheter compared to needle injections, really making sure that it was effective, because that's the biggest thing. When people are coming in for IVF, we will walk over hot coals for a baby, right?
Yeah.
If somebody has infertility, we will do anything for a baby. So efficacy is number one,
Yeah.
right? Of course. And so that's my first concern, is this effective? And so we measured FSH levels. FSH is the hormone that we give through injections, and we measured it in the blood, and there were no differences between using the subcutaneous catheter versus injections. And I should back up and talk about what this actually is. So it's a small device. It's about a quarter size. You can think of it like a glucose monitor that you see people with diabetes or insulin resistance or athletes wear on their arms or something
all
like
of
that.
our friends wear a levels glucose monitor.
So it looks just like that.
Yeah.
And same technology as an insulin pump. So it's essentially a small sticker that has a small flexible cannula that just sits right under the skin. We put it in the clinic. It's just an auto inserter. You press a button and it goes in, and you keep it in for the duration of the IVF cycle, and all of the medications can go through it. So women don't have to poke themselves at all at home. Everything goes through this catheter. And then when we take it out, it's like there was one tiny little poke there. It's nothing.
So do they attach the medication to it?
Yeah. So there's a cap, and then you remove the cap and put in this tubing that essentially twists onto the syringes for the medication. So the medication is exactly the same as if you're doing needle injections.
Wow.
It's just that you don't have to poke yourself.
Amazing.
So, I loved it when I went through. I was like, this took away so much of my anxiety and let me just focus on, am I going to get enough eggs? Am I going to make enough embryos? And made the process just a lot more palatable. And then in the clinical trial, patients loved it. We had some patients where this was a second cycle for them. They had done the first with needle injections, and they all said it was so much better. And so now I've really started growing this program, and I would say about 60 to 70% of my patients use it. There's some people who don't mind injections at all, and that's great. They can they don't have to wear something then. They can do the injections, and that's perfectly fine. But this is one option for people where the injections are a big hurdle to overcome that and make this process a little bit easier. As one of the last thing I'll say to it is, as a follow-up, we did another study where we just did a survey of everybody coming into the IVF clinic. And we asked them, okay, what are your top concerns about the IVF process? Is it cost? Is it number of eggs and embryos? Is it injections? Is it blood draws? And injections, we had this whole list. There were like 10 things that they selected, and big things. Is it transvaginal ultrasounds? Is it relationship dynamics? Is it all of these things that are stressors during the process? And injections were the third most common stressor that people had after cost and success of this.
Yeah.
So
I can imagine that.
Yeah. And over 2/3 of women had significant anxiety surrounding the injections. And even a percentage of those, about 20% of the people that had anxiety, said that they delayed coming in our door.
Wow.
Because of their fear of injections and how invasive this process was. So that to me is huge.
That do you do this for egg freezing too?
Of course, it's the same thing.
Wow.
And egg freezing is really, as I mentioned, women will walk through hot coals for a baby if they have infertility, right? But when people are thinking about freezing their eggs, this is also something that just makes the process look a little bit less daunting.
100%.
Yeah.
I honestly feel like I didn't freeze my eggs for that reason, because back then, 10 years ago, none of this existed.
Yeah.
That's incredible. And it would be interesting to see a clinical study that looks at stress levels. And if the stress levels are lower using this needle-free IVF, does that contribute to higher success levels?
Yeah. I mean, I think stress is something we're always trying to quantify in some way that's validated and, a reliable way to look at it. But yeah, I mean, I think just subjectively from hearing what my patients tell me
Yeah.
that this certainly impacts things. I can't translate it to, does it change actual IVF outcomes? But I think, now's the time. Look, I think we're kind of having this realization, which has come far too late in all things with women's health, that we have kind of ignored a lot of what women go through, right?
Yeah.
In pregnancy and childbirth and just general women's health, right? What we go through has been misunderstood, mischaracterized, and a lot of it ignored. And I think with IVF, it's a new technology, right? It's only been around for 40, 50 years.
Yeah.
And so IVF was truly a miracle, right? Creating babies. And as I mentioned, we would do anything. But now that IVF has become more commonplace and we've gotten better and better, and, over 3% of babies in this country are born through fertility technology, I think now's the time that we start critically evaluating it and saying, okay, we've met a lot of success. This has been amazing. But how can we now push the envelope a little bit and kind of try to make it a little bit more friendly for our patients?
Yeah.
So I think that's where, a different lens to look at this process, that maybe you don't need to inject yourself 3 times every day.
Amazing. So what are some other innovations that you're seeing in the field that you're excited about?
I think one of the big ones is genetics. I think that, as we start to advance our technology, our ability to sequence the whole genome of an embryo, I mean, that's wild. Taking a biopsy of, less than 10 cells and sequencing the entire genome of an embryo. I'm really excited to see where this takes us.
Yeah.
Now, part of why I went into this field is because I find the ethical issues completely fascinating. It will bring a lot of ethical issues, 100%, right? We'll have to think about what issues, what diseases, what conditions are we okay that a couple tries to prevent in their offspring, and what are we not okay with? Are we okay with designer babies? Are we, it's a slippery slope, right? As we start being able to test everything and really the whole genome in an embryo. And so I think that's technology that I'm very excited about, because I think it will help a lot of people, right? We'll be able to pick, now we do carrier screening to be able to understand, does a couple carry a genetic condition? How do we avoid an embryo in the next generation being affected with that condition? But now we might be able to pick up de novo things, right? Things that pop up in an embryo that we would have never been able to predict from both parents.
Yeah.
So I'm really excited about that and where it will take us. It's incredibly interesting and definitely fraught with ethical dilemmas. But I think that's why we just have to be responsible in using this technology.
Yeah. And same with, I feel like there's some ethical debate a little bit about picking your gender.
Yeah. Yeah. There definitely is an ethical debate about that. I think the majority of us feel like that's an acceptable thing to choose. We let patients choose sex all the time.
Which, by the way, that's a pretty new technology too.
Very new. And
I feel like 5 years ago, that was not possible.
Yeah. And really, it's just a accident, if you will, that we get this information, because when we're doing PGTA, which is really what the genetic testing is called, we are doing it to be able to, like we talked about before, doing it to be able to understand, does the embryo have the correct number of chromosomes? Because that is the most common cause for age-related egg quality issues, miscarriage, failed IVF.
Yeah.
And we learn sex chromosomes in that process, right? We learn that there's 22 of the autosomal, autosomes and 2 sex chromosomes. So we just learn that information. So, I think we believe that if it's a couple's desire to use that information to balance their family or choose one sex or the other, that's acceptable. Now, I think we might feel differently if we felt like, 80% of the children born from IVF were females or males or something. We might have to think a little bit more critically. But for now, I think people have been using it pretty responsibly.
Yeah. And the genetic testing, does everybody do genetic testing on embryos? Or is that just something that, I know that a lot of clinics in Los Angeles do.
Yeah.
And I feel like they increase, obviously, success rates a lot higher, but I feel like
it's a good question.
not everybody does it.
So not everybody does it. It's becoming more and more common because it just gives you more information about the embryo that you're transferring, and per embryo transfer increases success.
Yeah.
But certainly it's still a controversial thing, particularly like in young women where egg quality is thought to be quite high. So we expect that, 80% of the eggs should be normal. Then the question is, we have to biopsy the embryo to do this genetic testing. So we think for most people that this biopsy doesn't cause any
damage,
serious harm, or really that harm would be in decreasing the implantation potential of the embryo. So we don't think that it causes significant harm. But the question is, what do you gain? And if you don't gain, right, I gain information of knowing which embryo is most likely to lead to a pregnancy. But if I'm picking out of 10 eggs and 8 are likely, or 10 embryos and 8 are likely to be normal in a young person, then I'm not gaining that much, right?
Yeah.
If I choose one at random, it's probably a normal one.
Yeah.
So it's still controversial in young women or even donor egg, embryos that are coming from donor egg, which are young, healthy women. But certainly in older women, we see a lot of benefit because you're really just sparing several embryo transfers that may have led to no pregnancy or a miscarriage. But not everybody does it. It's definitely a conversation that I have with patients all the time as to whether or not to use this technology. If we're going to transfer everything we have anyway, then, there's not necessarily a reason to do it. But I think it's for the right patient population. So it's always a discussion.
Amazing. Well, I learned so much. There's still so much more to talk about. I'm so excited about your work and all the innovation that you're putting out. Thank you so much.
Yeah, thank you so much for having me. This was such a nice conversation, and I'm a big believer in WeNatal and your messaging and what you're doing for couples. I really think it's so fantastic. So I'm happy to support and happy to be involved.
Thank you.